Now we're going to be talking about stomatitis, and this is chapter 56, page 1193. It starts in Iggy. Stomatitis is inflammation of the mucous lining of any of the structures in the mouth, the cheeks, the lip, gingiva, or the floor or the roof of the mouth. It's usually painful, and it can be associated with redness, swelling, and sometimes bleeding. It affects people of all ages, and your book goes over the different types. There's the canker sores, which is the most frequent, which is also called aphthous ulcers, primary stomatitis, secondary stomatitis, and candida, which is a form of secondary stomatitis. The primary stomatitis is the most common, which includes those non-infectious stomatitis, herpes, simplex stomatitis, and traumatic type ulcers. Your secondary stomatitis generally results from infection by some form of opportunistic virus, fungi, or a bacteria in patients who are immunocompromised. It can also result from drugs, as we know, or chemotherapeutic type drugs. In addition, the mouth is also susceptible to the effects of HIV virus, and other types of systemic diseases can cause stomatitis, which includes chronic kidney disease, inflammatory bowel. Poor oral hygiene is a risk factor for certain infections, especially if the patient has been hospitalized, especially ventilator-assisted pneumonias. Stomatitis can result from infection, allergies, vitamin deficiency, systemic disease, irritants such as tobacco and alcohol. Infections such as bacteria and viruses can have a role in the development, especially of recurrent type of stomatitis. So certain foods can trigger allergic responses that can cause especially your most common type, your aphthous ulcers or your canker sores. Your foods such as caffeine, potatoes, cheese, nuts, citrus fruits, gluten can also be causative factors. In some cases, just a strict diet can result in the improvement of ulcers. Any deficiency in vitamin B complex, folate, zinc, iron, can also contribute to the formation of stomatitis. It's important to assess, to do an oral hygiene assessment at every time that we do our first assessment, to see if there's any kind of history of recurrent infections, nutritional changes, oral hygiene habits, their oral trauma, or any stress. Drug history is important to gather when you're looking at problems in the oral cavity. The symptoms can range, of stomatitis ranges in severity from a dry, painful mouth to open ulcers, which then predisposes the patient to infection. Of course, this can alter nutritional status because of difficulty with eating and or swallowing. And if you see anything in the back of the throat, you know that it probably extends down the back of the throat towards the esophagus. And then the patient can have difficulty swallowing, difficulty eating, and have swelling that can potentially obstruct the airway. So on our oral candida, which is a type of yeast infection, we'll have white plaque lesions that appear on the tongue. Now these lesions can be wiped away. In comparison to our Leukoplakia patients, that the white patches cannot be wiped away. The patient will report pain. They can also report lesions such as hot or dry. And remember that our patients who have any kind of systemic illness can develop candida, especially when taking antibiotics or chemo or steroids. So it's real important that we examine the mouth wearing non-sterile gloves, use adequate lighting, a pen light, tongue blade, assess the mouth for any lesions, coating, cracking. It's important to document the lesions, including their location, size, shape, odor from the mouth, color, or any drainage. Also palpate the cervical and submandibular mandibular lymph nodes for any type of swelling. That would be important as well. So on our interventions, the care of the patient with problems of the oral cavity on page 1194 is an excellent little chart. Chart 56-2. It basically says remove any dentures if the patient has severe stomatitis or any kind of oral pain. Encourage the patient to perform oral hygiene or provide it after each meal, especially if the patient cannot do it for himself, and as often as needed. Increase mouth care to every 2 hours or more frequently if that stomatitis is not controlled. Use a soft toothbrush. Encourage frequent rinsing of the mouth with saline or sodium bicarb or a combination of those two solutions. Make sure that you teach the patient to avoid any alcohol containing mouthwashes and do not use lemon glycerin swabs on them. Assist the patient in selecting soft, bland, non-acidic foods and apply those topical analgesics that's prescribed by the healthcare provider. That would be very important as well. So under our drug therapy, which is the next slide, that includes antimicrobials, immune modulators, systemic topical agents, antimicrobials, which would include our antibiotics, antivirals, antifungals, may be necessary for control of the infection. So our tetracycline, swish and swallow. The patient basically rinses for 2 minutes and then swallows, so you get that the benefit of topical and systemic therapy with this drug. Minocycline and chlorhexidine mouthwashes may also be used. Acyclovir can be given IV, oral, or topical. For our fungal infections, nystatin can be given, and that's another swish and swallow. For pain, they can be given Orabase, Anbesol, Campho-phenique. They also can be given vicious lidocaine for pain. Dietary changes are real important with these patients to help decrease pain. Any cold liquids can be very soothing for the patient. There is an evidence-based research regarding cold and ice before chemotherapy is given, usually 30 minutes before and during the chemo is given IV. That has really helped patients with stomatitis that are undergoing cancer treatment. So make sure that you include those foods that are high in protein, vitamin C, scrambled eggs, bananas, custard, ice cream are some of the choices that you can give to your patients, but not if they're, hopefully they're not lactose intolerant. So that ends stomatitis, and leukoplakia and erythroplakia are on a next lecture. Now we're going to be talking about leukoplakia. This is on page 1195 in IGI, and it kind of goes over our oral tumors, but we're not going to be talking about oral cancer this time around. We're just going to be talking about leukoplakia and erythroplakia. And leukoplakia presents as a slowly developing change in the oral mucous membrane that causes thickened, white, firmly attached patches that cannot easily be scraped off. Remember, we talked about stomatitis, and the type of stomatitis that has those white patches is candida. So that yeast or that fungal type infection with candida, that can be easily scraped off as compared to our leukoplakia that cannot be. These patches usually appear slightly raised and very sharply rounded. Most of them are benign. However, there is a very, very small percentage of them that can become cancerous. So the leukoplakia is usually found anywhere on the oral mucosa. Lesions on the lips or the tongue are most likely to progress to cancer. So we really have to be astute in our assessment of our oral cavity. Leukoplakia results from those mechanical type factors that can cause long-term irritation to the oral mucous membrane, such as poorly fitting dentures, chronic cheek nibbling, or broken or poorly repaired teeth. In addition, you can also see what they call oral hairy leukoplakia, which can be found in patients with HIV infection. Remember also that any kind of tobacco products, smoked, dipped, or chewed, have been implicated in the development of leukoplakia. It's also called that smoker's patch. Leukoplakia is one of the most common oral lesions among adults. Oral hairy leukoplakia is associated with Epstein-Barr and can be that early manifestation of HIV infection. The leukoplakia that's not associated with HIV infection is often seen in people older than 40, and usually men have twice the incidence of leukoplakia than women have, but since the age of smoking in women, that statistic is also changing. I think this slide just gives you a little bit of a picture of that oral hairy leukoplakia that's seen in HIV infection, and it's correlated with progression from that HIV to AIDS, which is a sad, sad thing. Erythroplakia is on page 1195 as well, and it's just a little paragraph. It just basically says if you find any kind of red velvet mucosal lesions at the surface of the oral mucosa, that's usually how this presents. They're usually more malignant changes than in leukoplakia, and this one is considered to be precancerous. They need to do a biopsy because a lot of times it can be difficult to distinguish from inflammatory or an immune reaction, so biopsy is the definitive diagnosis on this. And these are usually found most commonly on the floor of the mouth, the tongue, and the palate and mandibular mucosa.